Question 1. The audit findings indicate a recurring pattern of patient-reported difficulty with contact lens insertion and removal, despite documented in-office instruction. This suggests a potential gap in the effectiveness of the current patient education protocol. Which of the following strategies, when implemented as part of the contact lens fitting process, would most effectively address this audit finding and ensure patient competency according to ABCLF standards? Option A. Rely solely on verbal explanations of insertion and removal techniques during the fitting appointment, assuming the patient will be able to replicate the process at home. Option B. Incorporate a hands-on practice session where the patient attempts insertion and removal under direct supervision, followed by a review of their technique and provision of simplified, visual-based take-home instructions. Option C. Offer a brief demonstration of insertion and removal, followed by a quick verbal check to confirm the patient's understanding of the steps involved. Option D. Provide a comprehensive written manual detailing all aspects of contact lens care, including insertion and removal, and instruct the patient to read it thoroughly before their next appointment. Correct answer is B. Incorporate a hands-on practice session where the patient attempts insertion and removal under direct supervision, followed by a review of their technique and provision of simplified, visual-based take-home instructions. Explanation. This scenario is professionally challenging because it requires the contact lens fitter to balance the need for efficient patient education with the absolute necessity of ensuring patient safety and understanding. Inadequate instruction can lead to complications, patient dissatisfaction, and potential liability. The ABCLF certification emphasizes the importance of thorough patient instruction as a cornerstone of safe and effective contact lens practice. The correct approach involves a multifaceted strategy that prioritizes patient comprehension and skill acquisition. This includes demonstrating both insertion and removal techniques, allowing the patient to practice under supervision, and providing clear, concise written materials. This approach aligns with the ethical obligation to provide competent care and the regulatory expectation that practitioners ensure patients are adequately informed and capable of managing their contact lens wear. The ABCLF framework implicitly supports this by focusing on patient outcomes and the practitioner's responsibility in achieving them. An incorrect approach would be to solely rely on verbal instruction without demonstration or supervised practice. This fails to account for variations in patient learning styles and dexterity, increasing the risk of improper technique, lens damage, or ocular irritation. Ethically, this falls short of the duty of care. Another incorrect approach is providing only written instructions, which can be overwhelming or misunderstood by patients, especially those with limited literacy or visual impairments. This bypasses the crucial interactive element of education. Finally, assuming patient competence without observation or asking clarifying questions is a significant failure, as it neglects the practitioner's responsibility to verify understanding and skill. This can lead to a false sense of security for both the patient and the practitioner, potentially masking underlying issues that could result in adverse events. Professionals should approach patient education by first assessing the patient's individual needs and learning style. This involves active listening and observation. The education process should be interactive, incorporating demonstration, supervised practice, and opportunities for the patient to ask questions. Reinforcement through written materials tailored to the patient's comprehension level is also vital. The ultimate goal is to empower the patient to safely and effectively manage their contact lens wear independently. Question 2. Market research demonstrates that patients seeking contact lens fittings are increasingly aware of general eye health, including retinal conditions. During a routine contact lens fitting, a fitter observes subtle, irregular pigmentary changes in the peripheral retina of a patient who reports no visual symptoms. The fitter suspects these changes could be early signs of a degenerative retinal condition. Considering the ABCLF certification's focus on patient care and scope of practice, what is the most appropriate course of action? Option A. Document the observed retinal changes. Explain to the patient that these are common age-related variations and do not impact contact lens wear, and proceed with the fitting. Option B. Attempt to manage the suspected retinal condition by adjusting the contact lens parameters to compensate for any potential visual field defects, while advising the patient to report any worsening symptoms. Option C. Advise the patient that the observed retinal changes are likely benign, and that they should monitor their vision for any changes, continuing with their current contact lens prescription. Option D. Immediately refer the patient to an ophthalmologist for a comprehensive retinal evaluation, explaining that the observed changes require specialist assessment to rule out any potential underlying pathology that could affect their vision or contact lens tolerance. The correct answer is A. Document the observed retinal changes. Explain to the patient that these are common age-related variations and do not impact contact lens wear, and proceed with the fitting. Explanation. This scenario is professionally challenging because it requires the contact lens fitter to integrate knowledge of ocular anatomy and pathology with patient communication and management, all within the strict confines of ABCLF certification standards. The fitter must not only identify potential retinal issues, but also communicate these findings appropriately to the patient and potentially refer them for further evaluation, adhering to ethical and professional guidelines. The core challenge lies in balancing the need for thorough examination and patient education with the scope of practice for a contact lens fitter. The correct approach involves a comprehensive assessment of the patient's retinal health during the contact lens fitting process, recognizing signs and symptoms indicative of retinal pathology, and then clearly and accurately communicating these findings to the patient. This includes explaining the potential implications for their vision and contact lens wear, and recommending appropriate follow-up with an ophthalmologist or other qualified eye care professional for definitive diagnosis and management. This approach aligns with the ABCLF emphasis on patient safety and the ethical responsibility to refer when a condition falls outside the fitter's scope of practice or requires specialized medical attention. The ABCLF certification implies a commitment to a high standard of care, which includes recognizing and acting upon findings that could compromise a patient's ocular health. An incorrect approach would be to dismiss subtle retinal findings as insignificant or unrelated to contact lens, where without further investigation or referral, this failure to recognize potential pathology could lead to delayed diagnosis and treatment, potentially resulting in irreversible vision loss for the patient. Ethically, this constitutes a breach of the duty of care. Another incorrect approach would be to provide a definitive diagnosis of a retinal disease, which exceeds the scope of practice for a contact lens fitter and could mislead the patient. This misrepresentation of professional capabilities is both unethical and potentially harmful. Finally, failing to adequately inform the patient about the observed retinal findings and the necessity of further evaluation by a specialist is a dereliction of the fitter's responsibility to ensure the patient understands their ocular health status and the recommended course of action. The professional decision-making process for similar situations should involve a systematic approach. First, conduct a thorough and complete eye examination, including assessment of the retina as per standard contact lens fitting protocols. Second, critically evaluate any observed abnormalities, considering their potential impact on vision and contact lens wear. Third, consult relevant ABCLF guidelines and ethical codes to determine the appropriate course of action, including when referral is necessary. Fourth, communicate findings and recommendations to the patient in a clear, understandable, and empathetic manner, ensuring they comprehend the importance of follow-up care. Question 3. Risk assessment procedures indicate that a patient presents for a routine contact lens evaluation with a history of intermittent redness and discomfort, particularly at the end of the day. Upon examination, the fitter observes mild meibomian gland dysfunction, MGD, characterized by capped glands and poor meibum quality, along with some eyelash debris at the lid margins. Which of the following approaches best reflects the professional's responsibility in managing this situation for safe and effective contact lens wear? Option A. Recommend discontinuing contact lens wear indefinitely until the eyelid condition resolves completely, without offering alternative management strategies or contact lens options. Option B. Conduct a thorough assessment of the eyelids and ocular surface, document the findings of MGD and lid margin debris, and develop a management plan that may include lid hygiene, warm compresses, and potentially modifying the contact lens type or wearing schedule, while educating the patient on the condition. Option C. Dispense new contact lenses without further investigation, assuming the patient's symptoms are due to dry eyes unrelated to their eyelids. Option D. Proceed with fitting the patient in their current contact lens prescription, advising them to use artificial tears more frequently. The correct answer is D. Proceed with fitting the patient in their current contact lens prescription, advising them to use artificial tears more frequently. Explanation. Scenario analysis. This scenario presents a common challenge in contact lens fitting where a patient's eyelid health directly impacts the safety and efficacy of contact lens wear. The challenge lies in accurately identifying subtle signs of eyelid disease, understanding its potential implications for the ocular surface and contact lens tolerance, and then formulating an appropriate management plan that prioritizes patient well-being and adherence to professional standards. Misjudgment can lead to discomfort, reduced vision, ocular surface damage, and potentially serious infections, all of which fall under the purview of responsible contact lens practice. Correct approach analysis. The correct approach involves a thorough assessment of the patient's eyelids, including visual inspection for signs of inflammation, debris, or structural abnormalities, and palpation to assess for tenderness or masses. This is followed by a careful evaluation of the ocular surface for signs of dryness, inflammation, or damage that may be related to eyelid dysfunction. The professional then considers the implications of any findings for contact lens wear, such as potential for reduced lens-to-cornea adherence, increased microbial contamination, or exacerbation of symptoms. Based on this comprehensive assessment, the professional makes an informed decision regarding the suitability of contact lens wear, the type of lens, wearing schedule, and necessary management strategies for the eyelid condition. This aligns with the ABCLF emphasis on patient safety, comprehensive eye care, and evidence-based practice, ensuring that contact lens fitting is performed within the bounds of safe and effective ocular health management. Incorrect approaches analysis. An approach that solely focuses on dispensing contact lenses without a detailed eyelid examination, assuming the patient's eyelids are healthy, fails to adhere to the fundamental principles of contact lens fitting. This neglects the potential for underlying eyelid pathology to compromise ocular health and contact lens performance, violating the professional's duty of care. An approach that identifies eyelid abnormalities but proceeds with contact lens fitting without considering the impact on the ocular surface or patient symptoms, or without recommending appropriate management for the eyelid condition, demonstrates a lack of comprehensive patient assessment and risk management. This could lead to adverse events and a failure to provide optimal care. An approach that dismisses patient-reported symptoms related to their eyelids as unrelated to contact lens, where without objective examination and consideration of potential etiologies, is also professionally unsound. This overlooks the interconnectedness of the ocular surface, eyelids, and contact lens, where, potentially leading to misdiagnosis and inadequate treatment. Professional reasoning. Professionals should adopt a systematic approach to contact lens fitting that begins with a comprehensive patient history and a thorough ocular examination, including detailed assessment of the eyelids and ocular surface. Any identified abnormalities should be carefully evaluated for their potential impact on contact lens wear and ocular health. Decision-making should be guided by evidence-based practice, patient-specific factors, and a commitment to minimizing risk and maximizing visual and ocular health outcomes. This involves a continuous process of assessment, diagnosis, treatment planning, and follow-up. Question 4. Risk assessment procedures indicate a contact lens wearer presence with new-onset floaters and a subjective decrease in visual acuity. The contact lens fit appears adequate, and the ocular surface shows no signs of inflammation or infection. Which of the following approaches best aligns with the regulatory framework for contact lens fitters in managing this patient? Option A. Reassure the patient that the floaters are benign and will resolve on their own, without any further examination. Option B. Attempt to manage the floaters by prescribing a different contact lens material or solution without further investigation. Option C. Immediately refer the patient to an ophthalmologist for a dilated fundus examination to evaluate for vitreous pathology after confirming no contact lens-related complications. Option D. Advise the patient that floaters are a common side effect of contact lens wear and continue with the current lens wear. The correct answer is C. Immediately refer the patient to an ophthalmologist for a dilated fundus examination to evaluate for vitreous pathology after confirming no contact lens-related complications. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires the contact lens fitter to differentiate between a potential contact lens-related complication and a primary vitreous abnormality. This diagnosis can lead to inappropriate management, potentially causing harm to the patient's vision and delaying necessary treatment for either condition. The challenge lies in the subtle overlap of symptoms and the need for precise clinical observation and differential diagnosis within the scope of practice. Correct approach analysis. The correct approach involves a comprehensive assessment that prioritizes ruling out contact lens-induced pathology. This is justified by the ABCLF emphasis on patient safety and the fitter's primary responsibility for contact lens-related care. The regulatory framework mandates that contact lens fitters identify and manage complications arising from contact lens wear. Therefore, a systematic evaluation, starting with the contact lens fit, ocular surface health, and potential for microbial keratitis or sterile infiltrates, is paramount. If these are ruled out, then referral for further investigation of the vitreous is the appropriate next step, adhering to the scope of practice and ensuring the patient receives specialized care for suspected intraocular conditions. Incorrect approaches analysis. An approach that immediately assumes a primary vitreous issue without thoroughly investigating contact lens-related causes is professionally unacceptable. This fails to adhere to the ABCLF mandate to manage contact lens complications. It bypasses the fitter's core responsibilities and could lead to a missed or delayed diagnosis of a contact lens-related problem, such as a severe keratitis, which requires immediate contact lens removal and treatment. Another incorrect approach would be to attribute any vitreous opacities solely to the contact lens without further investigation. This oversimplifies the diagnostic process and ignores the possibility of independent vitreous pathology, such as floaters, posterior vitreous detachment, or even more serious conditions like uveitis or vitreous hemorrhage, which are outside the direct management scope of a contact lens fitter, but require appropriate referral. A third incorrect approach is to manage the presumed vitreous issue with contact lens modifications or solutions without a definitive diagnosis. This is a direct violation of professional standards, as it involves therapeutic intervention without a clear understanding of the underlying cause and could mask or exacerbate a serious condition. The ABCLF guidelines emphasize evidence-based practice and appropriate referral pathways. Professional reasoning. Professionals in this field must adopt a systematic, evidence-based approach to patient care. This involves a thorough history, comprehensive ocular examination, and a differential diagnosis that prioritizes conditions within their scope of practice. When symptoms or signs suggest pathology beyond their expertise, the ethical and regulatory imperative is to refer the patient to the appropriate specialist. This ensures patient safety, adherence to professional standards, and optimal health outcomes. The decision-making process should always begin with the most probable cause related to the fitter's direct area of responsibility, contact lens wear, and then systematically expand to consider other possibilities, leading to appropriate referral when necessary. Question 5. The evaluation methodology shows a 55-year-old patient presenting for routine contact lens follow-up. The patient reports no changes in vision or discomfort. During the slit lamp examination, you note a slightly increased cup-to-disc ratio in the right eye compared to the left, with some subtle pallor of the neuroretinal rim. The patient denies any family history of glaucoma. What is the most appropriate next step in managing this patient's contact lens fitting and overall ocular health? Option A. Reassure the patient that the observed optic nerve changes are likely age-related and not clinically significant, and continue with the contact lens fitting. Option B. Perform a detailed assessment of the optic nerve head, including stereoscopic examination and documentation of the cup-to-disc ratio and rim appearance, and conduct a visual field test to objectively assess visual function. Option C. Immediately discontinue contact lens wear and refer the patient to an ophthalmologist for a comprehensive glaucoma workup due to the observed optic nerve changes. Option D. Document the findings, advise the patient to report any visual changes, and proceed with the contact lens prescription as planned, as the patient is asymptomatic. Correct answer is D. Document the findings, advise the patient to report any visual changes, and proceed with the contact lens prescription as planned, as the patient is asymptomatic. Explanation. The evaluation methodology shows a scenario that is professionally challenging due to the subtle and potentially progressive nature of optic neuropathies, which can significantly impact a patient's vision and quality of life. Contact lens fitter must exercise careful judgment to differentiate between normal variations and pathological findings, especially when a patient is asymptomatic or reports nonspecific symptoms. The responsibility extends beyond fitting contact lenses to recognizing signs that may indicate a serious underlying condition requiring referral. The correct approach involves a thorough assessment of the optic nerve head, including its color, cup-to-disc ratio, and the presence of any hemorrhages or edema, in conjunction with a comprehensive visual field assessment. This systematic evaluation, when combined with a detailed patient history and consideration of risk factors, allows for the identification of potential optic neuropathies. Regulatory frameworks and ethical guidelines for contact lens fitters emphasize the paramount importance of patient safety and the duty to recognize and manage conditions that fall within their scope of practice or to refer appropriately. Early detection and intervention are critical for preserving vision, aligning with the professional obligation to act in the best interest of the patient. An incorrect approach would be to dismiss subtle changes in optic nerve appearance or minor visual field defects as insignificant, particularly if the patient reports no subjective visual complaints. This failure to investigate further could lead to a delayed diagnosis of a serious optic neuropathy, such as glaucoma or ischemic optic neuropathy, resulting in irreversible vision loss. Such an oversight would violate the ethical duty of care and potentially contravene regulatory requirements for diligent patient assessment. Another incorrect approach is to rely solely on the patient's subjective report of vision without objective clinical findings. While patient symptoms are important, many optic neuropathies are asymptomatic in their early stages. Ignoring objective signs of optic nerve compromise because the patient feels fine is a significant professional failing. A third incorrect approach is to attribute any observed optic nerve abnormality solely to contact lens without considering other potential etiologies. While contact lens-induced complications can affect the optic nerve, a comprehensive differential diagnosis is essential. Failing to consider systemic conditions or other ocular diseases that can cause optic neuropathy would be a critical error. The professional decision-making process for similar situations should involve a structured approach. 1. Gather a comprehensive patient history, including ocular and systemic health and any relevant family history. 2. Perform a thorough ocular examination, with specific attention to the optic nerve head using appropriate magnification and illumination, and document findings meticulously. 3. Conduct objective functional testing, such as visual field perimetry, if indicated by the optic nerve appearance or patient history. 4. Correlate all findings and consider potential differential diagnoses. 5. If any suspicion of optic neuropathy arises, or if findings are outside the scope of practice for a contact lens fitter, refer the patient promptly to an ophthalmologist for further evaluation and management. This systematic process ensures that patient care is prioritized and that potential sight-threatening conditions are not overlooked. Question 6. The performance metrics show a consistent pattern of reduced visual acuity in a patient fitted with new contact lenses, particularly in low-light conditions. Which of the following diagnostic approaches best addresses the potential anatomical and physiological underpinnings of this visual deficit? Option A. Focus solely on the lens fit and centration, assuming any visual issues are unrelated to the lens itself. Option B. Inquire about the patient's subjective experience of glare and light scatter, and suggest a trial of tinted contact lenses. Option C. Assess pupillary response to light and evaluate the tear film's optical quality using a wavefront aberrometer, correlating findings with corneal topography. Option D. Recommend a period of lens wear without further examination, assuming visual acuity will improve with adaptation. The correct answer is C. Assess pupillary response to light and evaluate the tear film's optical quality using a wavefront aberrometer, correlating findings with corneal topography. Explanation. The performance metrics show a consistent pattern of reduced visual acuity in a patient fitted with new contact lenses, particularly in low-light conditions. This scenario is professionally challenging because it requires the contact lens fitter to move beyond simply assessing lens fit and comfort to investigating potential physiological impacts on vision. The fitter must consider how the lens material, design, and fit interact with the complex anatomy and physiology of the eye, specifically the cornea, and its interaction with light. The ABCLF certification emphasizes a comprehensive understanding of ocular health and function, not just lens dispensing. The correct approach involves a thorough assessment of the ocular structures and their physiological responses to the contact lens. This includes evaluating corneal topography, tear film dynamics, and pupillary response in varying light conditions. Understanding how these factors influence light refraction and transmission is crucial. For instance, a lens that induces aberrations or alters the tear film's optical quality can significantly impact visual acuity, especially in low light when the pupil dilates and aberrations become more pronounced. This approach aligns with the ABCLF mandate to ensure patient safety and optimal visual outcomes by applying knowledge of ocular anatomy and physiology to contact lens fitting. An incorrect approach would be to attribute the reduced visual acuity solely to lens adaptation, or to dismiss it as a subjective complaint without further investigation. Failing to investigate the underlying physiological causes of reduced visual acuity, such as corneal edema, irregular astigmatism induced by the lens, or poor tear film quality affecting optical clarity, represents a failure to adhere to professional standards of care. Such an approach neglects the responsibility to diagnose and manage potential complications arising from contact lens wear, which could have long-term implications for ocular health and vision. It also fails to uphold the ethical obligation to provide the highest standard of care. Another incorrect approach would be to immediately recommend a different lens material or design without a systematic evaluation of the current lens's interaction with the eye's physiology. This bypasses the critical step of understanding why the vision is compromised. Without a physiological diagnosis, changing the lens might not address the root cause and could even introduce new problems. This reactive approach lacks the analytical rigor expected of a certified contact lens fitter. The professional decision-making process for similar situations should involve a systematic, evidence-based approach. First, gather all available data, including patient history, subjective complaints, and objective measurements. Second, formulate hypotheses based on the understanding of ocular anatomy and physiology and how contact lenses interact with these structures. Third, design and execute diagnostic tests to confirm or refute these hypotheses. Fourth, develop a management plan based on the confirmed diagnosis, prioritizing patient safety and visual function. This iterative process ensures that interventions are targeted and effective, reflecting a deep understanding of the subject matter. Question 7. The audit findings indicate a pattern of elevated intraocular pressure measurements during routine contact lens fitting appointments for a specific patient, coupled with anatomical descriptions of a narrow anterior chamber angle in the same patient's records. What is the most appropriate course of action for the contact lens fitter? Option A. Advise the patient that contact lens wear may be contributing to their elevated intraocular pressure and suggest discontinuing wear. Option B. Immediately refer the patient to an ophthalmologist for a comprehensive glaucoma evaluation. Option C. Document the findings and continue with the current contact lens prescription, advising the patient to monitor for symptoms. Option D. Adjust the contact lens parameters to potentially reduce intraocular pressure and reevaluate in a month. The correct answer is C. Document the findings and continue with the current contact lens prescription, advising the patient to monitor for symptoms. Explanation. This scenario presents a professional challenge because it requires the contact lens fitter to interpret audit findings related to anterior chamber health and glaucoma risk, directly impacting patient care and the scope of practice. The fitter must demonstrate a thorough understanding of aqueous humor dynamics, angle anatomy, and the early signs of glaucoma, as well as the ethical and regulatory obligations to refer or manage appropriately. The challenge lies in distinguishing between normal anatomical variations and pathological conditions that necessitate further investigation or intervention, all within the defined parameters of contact lens fitting practice. The correct approach involves a comprehensive review of the audit findings, correlating them with the patient's clinical presentation and contact lens history. This approach is correct because it prioritizes patient safety and adheres to the ABCLF ethical guidelines and the implied scope of practice, which includes recognizing potential ocular health issues that may be exacerbated or masked by contact lens wear. Specifically, understanding aqueous humor production, circulation, and drainage is fundamental to assessing intraocular pressure (IOP) and the risk of glaucoma. Evaluating angle anatomy is crucial for identifying potential predispositions to angle closure glaucoma. By recognizing findings suggestive of compromised drainage or anatomical risk factors, the fitter is ethically and professionally obligated to take appropriate action, which may include referral to an ophthalmologist for definitive diagnosis and management of glaucoma. This aligns with the principle of acting in the best interest of the patient and practicing within one's defined competency. An incorrect approach would be to dismiss the audit findings as irrelevant to contact lens fitting. This fails to acknowledge the interconnectedness of ocular health and contact lens wear. The regulatory framework for contact lens fitters, while focused on fitting, implicitly requires the practitioner to be aware of and respond to signs of ocular pathology that could affect the safety and efficacy of contact lens wear or indicate a more serious underlying condition like glaucoma. Ignoring such findings constitutes a failure to uphold professional responsibility and could lead to delayed diagnosis and treatment of a sight-threatening condition. Another incorrect approach would be to attempt to diagnose or manage glaucoma without the appropriate qualifications or scope of practice. While the fitter may identify risk factors or suspicious findings, the definitive diagnosis and management of glaucoma fall under the purview of ophthalmology. Overstepping these boundaries is a violation of professional ethics and potentially regulatory guidelines, as it can lead to inappropriate treatment or a false sense of security for the patient. A third incorrect approach would be to solely focus on the contact lens fit without considering the anterior chamber health implications. While a proper contact lens fit is paramount, it should not supersede the assessment of the overall health of the anterior segment. Audit findings related to aqueous humor dynamics or angle anatomy are direct indicators of anterior segment health and potential glaucoma risk, and therefore must be integrated into the overall patient assessment. The professional decision-making process for similar situations should involve a systematic evaluation of all available data, including audit findings, patient history, and clinical observations. The fitter must then assess these findings against their scope of practice and ethical obligations. When findings suggest a potential ocular health issue, particularly one as serious as glaucoma, the primary decision should be whether referral to a specialist is warranted. This involves understanding the limitations of their own expertise and prioritizing the patient's well-being by ensuring they receive appropriate medical care from the most qualified professional. Question 8. The risk matrix shows that selecting the correct contact lens power for a patient with a high myopic refractive error and astigmatism, who is also presbyopic, presents a moderate risk of suboptimal visual outcomes if not handled with precision. Considering the principles of contact lens optics and the need for accurate correction across different visual demands, which of the following approaches best mitigates this risk? Option A. Directly transposing the spectacle prescription to the contact lens power, assuming standard vertex distance compensation is implicitly handled by the lens manufacturer. Option B. Calculating the spherical equivalent for the distance prescription, and then adding a power based on a general rule of thumb for presbyopia, without specific consideration for the astigmatism or the lens design's multifocal properties. Option C. Choosing a contact lens power that is the closest available standard power to the spectacle prescription, prioritizing ease of dispensing over precise optical correction. Option D. Performing vertex distance compensation for the high myopic refractive error, calculating the appropriate spherical and cylindrical powers for the contact lens, and then selecting a multifocal contact lens design that incorporates appropriate power profiles for both distance and near vision based on the patient's specific needs. The correct answer is A. Directly transposing the spectacle prescription to the contact lens power, assuming standard vertex distance compensation is implicitly handled by the lens manufacturer. Explanation. This scenario is professionally challenging because it requires the contact lens fitter to select the appropriate lens power for a patient with a complex refractive error. Considering both the refractive error itself and the specific characteristics of the contact lens material and design, miscalculation or inappropriate selection can lead to suboptimal visual acuity, patient discomfort, and potentially ocular health issues, all of which fall under the purview of professional responsibility and ethical practice as defined by the American Board of Contact Lens Fitters, ABCLF, certification standards. The correct approach involves a thorough understanding of how different refractive errors, e.g., myopia, hyperopia, astigmatism, presbyopia, interact with the optical properties of various contact lens types, e.g., soft spherical, soft toric, rigid gas permeable, multifocal. This includes considering factors such as vertex distance compensation for high refractive errors, the impact of lens base curve and diameter on fit and optics, and the specific power calculations required for multifocal designs to achieve adequate distance and near vision. This approach aligns with the ABCLF emphasis on patient-centered care and the application of sound optical principles to achieve the best possible visual outcome and ocular health, which are implicit in maintaining professional competence and ethical conduct. An incorrect approach that relies solely on a direct translation of spectacle prescription to contact lens power, without accounting for vertex distance for high prescriptions, fails to adhere to fundamental optical principles and can result in inaccurate correction, leading to blurred vision. This demonstrates a lack of due diligence and a failure to apply knowledge required for competent contact lens fitting, potentially violating ethical obligations to provide accurate and effective vision correction. Another incorrect approach that ignores the specific optical design of a multifocal contact lens and simply averages the distance and near powers would lead to compromised vision at both distances, failing to meet the patient's functional needs. This reflects a superficial understanding of lens optics and a disregard for the patient's visual requirements, which is an ethical failing in providing appropriate care. Furthermore, an approach that prioritizes ease of ordering over accurate optical correction, for instance, by selecting a standard power that is close enough without proper calculation or consideration of the patient's specific refractive error and lens type, is a direct contravention of the professional duty to provide precise and individualized care. This demonstrates a lack of commitment to the highest standards of practice and an abdication of responsibility for patient outcomes. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's refractive error, visual demands, and ocular health. This includes consulting relevant optical principles, understanding the specific characteristics of the chosen contact lens modality, and performing necessary calculations or adjustments to ensure optimal visual performance and ocular comfort. Adherence to established guidelines and a commitment to continuous learning are paramount in navigating these complex fitting scenarios. Question 9. What factors determine the optimal contact lens modality and fitting parameters for a patient presenting for a routine contact lens evaluation, considering both visual performance and ocular health? Option A. Solely relying on the patient's stated preference for a particular lens brand or type without clinical assessment. Option B. Adhering strictly to the lens manufacturer's standard fitting guidelines without considering individual patient variations. Option C. A comprehensive evaluation of the lens-cornea relationship, tear film status, and the patient's subjective feedback on comfort and vision. Option D. Prioritizing the highest achievable visual acuity as measured by the Snellen chart, regardless of lens fit or patient comfort. Correct answer is C. A comprehensive evaluation of the lens-cornea relationship, tear film status, and the patient's subjective feedback on comfort and vision. Explanation. This scenario is professionally challenging because it requires the contact lens fitter to balance patient comfort, visual acuity, ocular health, and the practicalities of lens wear, all while adhering to the ethical and regulatory standards set by the American Board of Contact Lens Fitters, ABCLF. The ABCLF certification implies a commitment to patient-centered care and evidence-based practice, necessitating a thorough and systematic approach to fitting and evaluation. The correct approach involves a comprehensive assessment of the lens-cornea relationship, tear film dynamics, and the patient's subjective experience. This systematic evaluation ensures that the chosen contact lens modality is not only comfortable and provides adequate vision, but also maintains ocular health and minimizes the risk of complications. This aligns with the ABCLF emphasis on professional competence and patient well-being, which are foundational ethical principles in contact lens practice. An approach that prioritizes only immediate visual acuity without considering lens fit or ocular health is ethically and professionally deficient. It risks overlooking subtle signs of corneal compromise or discomfort that could lead to serious complications, violating the duty of care owed to the patient. Similarly, an approach that solely focuses on patient preference without a thorough clinical evaluation may lead to an inappropriate lens selection that compromises ocular health or visual performance in the long term. Relying solely on manufacturer recommendations without independent clinical judgment fails to acknowledge the unique anatomical and physiological variations among patients, potentially leading to suboptimal outcomes and contravening the professional responsibility to tailor care to the individual. Professionals should employ a decision-making process that begins with a thorough patient history and pre-fitting assessment. This is followed by objective measurements, e.g., keratometry, refraction, corneal topography if indicated, and then the trial fitting of contact lenses. During the trial, meticulous evaluation of lens fit, movement, centration, tear film breakup time, and corneal staining is crucial. Subjective feedback from the patient regarding comfort and vision is also vital. This iterative process, guided by clinical expertise and regulatory guidelines, ensures the selection of the most appropriate lens for the individual patient's needs and ocular health. Question 10. Examination of the data shows a contact lens wearer presenting with intermittent double vision, particularly when looking to the left, and a subjective complaint of eye strain that has worsened over the past week. The patient denies any recent changes to their contact lens solution or wearing schedule, and their current lenses are within their prescribed replacement cycle. Which of the following represents the most appropriate next step in managing this patient's presentation? Option A. Increase the oxygen permeability of the patient's current contact lenses and recommend artificial tears to address the eye strain and potential hypoxia. Option B. Conduct a thorough assessment of the patient's extraocular muscle function, including motility, vergence, and fixation. And if abnormalities are noted that are not directly attributable to contact lens complications, refer the patient to an ophthalmologist or neurologist for further evaluation. Option C. Advise the patient to discontinue contact lens wear for a week and switch to spectacles to see if the symptoms resolve, assuming the issue is related to lens fit or solution sensitivity. Option D. Prescribe a new, higher-powered contact lens prescription to compensate for any perceived visual distortion causing the double vision. The correct answer is B. Conduct a thorough assessment of the patient's extraocular muscle function, including motility, vergence, and fixation, and if abnormalities are noted that are not directly attributable to contact lens complications, refer the patient to an ophthalmologist or neurologist for further evaluation. Explanation. Scenario analysis. This scenario presents a common challenge in contact lens practice where a patient exhibits symptoms that could be attributed to various causes, including issues with extraocular muscle function. Differentiating between a primary ocular muscle disorder and a contact lens-related complication requires careful clinical assessment and a thorough understanding of neuroanatomy and ocular motility. The professional challenge lies in accurately diagnosing the root cause to ensure appropriate management, prevent further complications, and maintain patient trust. Misdiagnosis could lead to ineffective treatment, patient dissatisfaction, and potential harm. Correct approach analysis. The correct approach involves a systematic evaluation of the patient's symptoms in the context of their contact lens wear and a comprehensive assessment of extraocular muscle function. This includes observing eye movements, assessing for diplopia, and considering potential neurological or muscular etiologies. Given the ABCLF certification's focus on contact lens fitting and management, the practitioner must first rule out contact lens-induced issues that might mimic or exacerbate extraocular muscle problems. If contact lens issues are ruled out or appear secondary, referral to an ophthalmologist or neurologist specializing in strabismus or neuro-ophthalmology is the appropriate next step. This aligns with the ethical and regulatory expectation for practitioners to operate within their scope of practice and to seek specialized consultation when patient care necessitates it. The ABCLF framework implicitly supports this by emphasizing patient safety and optimal vision outcomes, which require accurate diagnosis and appropriate referral pathways. Incorrect approaches analysis. An approach that immediately attributes the symptoms solely to contact lens overwear or poor hygiene, without a thorough assessment of extraocular muscle function, is flawed. While contact lens issues can cause discomfort and visual disturbances, they typically do not directly cause sustained diplopia or manifest as specific extraocular muscle palsies. This approach fails to consider the broader differential diagnosis and could lead to delayed or incorrect treatment. Another incorrect approach would be to prescribe new contact lenses or adjust the current prescription without investigating the underlying cause of the visual symptoms. This bypasses the critical diagnostic step and risks masking a more serious condition or exacerbating the existing problem. It disregards the potential for a primary neurological or muscular disorder. Finally, an approach that involves attempting to manage a suspected extraocular muscle disorder without appropriate consultation or referral is outside the typical scope of practice for a contact lens fitter. While understanding the principles of ocular motility is crucial for contact lens fitting, diagnosing and managing specific muscle disorders requires specialized medical training and expertise. This approach could lead to inappropriate interventions and potentially compromise patient safety. Professional reasoning. Professionals in this field must adopt a systematic diagnostic process. This begins with a detailed patient history, followed by a comprehensive ocular examination, including specific tests for extraocular muscle function and binocular vision. When symptoms suggest a condition beyond the scope of contact lens fitting, such as a suspected extraocular muscle disorder, the professional's responsibility is to recognize the limitations of their expertise and initiate a referral to the appropriate medical specialist. This ensures the patient receives the highest standard of care and that all potential etiologies are thoroughly investigated. Question 11. When evaluating a patient experiencing intermittent visual distortions with a multifocal contact lens, which approach best reflects adherence to ABCLF best practices for lens design evaluation? Option A. Immediately recommend a switch to a different type of multifocal lens design without a detailed analysis of the current lens's performance or the patient's specific visual complaints. Option B. Assume the visual distortions are an inherent limitation of multifocal lens technology and advise the patient to adapt to the visual compromise. Option C. Focus solely on the physical fit of the lens, ensuring it is stable on the eye, and disregard subjective visual quality complaints if visual acuity is within acceptable limits. Option D. Systematically assess the patient's visual acuity at distance and near, evaluate lens centration and movement, and inquire about specific visual disturbances such as glare or ghosting, correlating these findings with the intended visual performance of the multifocal design. The correct answer is D. Systematically assess the patient's visual acuity at distance and near, evaluate lens centration and movement, and inquire about specific visual disturbances such as glare or ghosting, correlating these findings with the intended visual performance of the multifocal design. Explanation. This scenario is professionally challenging because it requires the contact lens fitter to balance patient-reported symptoms with objective clinical findings, while adhering to the ABCLF ethical guidelines and the principles of best practice in contact lens fitting. The patient's subjective experience of visual quality is paramount, but it must be interpreted within the context of the lens design's intended function and the fitter's clinical assessment. The ABCLF certification implies a commitment to patient-centered care, evidence-based practice, and professional integrity, all of which are tested in such a situation. The correct approach involves a thorough assessment of the patient's visual acuity, contrast sensitivity, and subjective visual quality in relation to the specific lens design's capabilities and limitations. This includes understanding how spherical, toric, multifocal, and aspheric designs function and what visual outcomes they are intended to achieve. For a multifocal lens, the fitter must evaluate if the patient is experiencing appropriate visual function at various distances, considering potential issues like glare, halos, or ghosting, and whether these are within acceptable parameters for the chosen design. The fitter must then correlate these findings with the lens fit, centration, and the patient's ocular health. This approach aligns with the ABCLF emphasis on comprehensive patient evaluation and the ethical obligation to provide the most appropriate lens for the patient's visual needs and ocular health, ensuring informed consent and patient satisfaction. An incorrect approach would be to dismiss the patient's complaints of visual disturbances simply because the lens is technically correctly fitted or because the symptoms are common for the lens type. This fails to acknowledge the patient's subjective experience and the fitter's responsibility to optimize visual performance. Another incorrect approach would be to immediately switch to a different lens design without a systematic evaluation of the current lens's performance and the underlying cause of the visual disturbances. This could lead to unnecessary lens changes, increased costs for the patient, and a failure to address the root problem. Furthermore, assuming that any visual compromise is acceptable with a particular lens design, without attempting to mitigate or resolve it, demonstrates a lack of commitment to achieving the best possible visual outcome for the patient. Professional decision-making in such situations requires a systematic process. First, Actively listen to and validate the patient's concerns. Second, conduct a comprehensive clinical assessment, including visual acuity, refraction, lens fit, and ocular health. Third, critically evaluate the performance of the current lens design against its intended purpose and the patient's visual demands. Fourth, consider potential modifications or alternative lens designs based on the assessment, always prioritizing the patient's visual needs and ocular health. Finally, engage in shared decision-making with the patient, explaining the findings, options, and rationale for any proposed course of action. Question 12. The risk matrix shows a moderate likelihood of patient-reported discomfort and reduced visual acuity with a specific hydrogel contact lens. Considering the ABCLF certification requirements for understanding contact lens materials, which of the following approaches best addresses this situation? Option A. Immediately assume the lens fit is too tight or too loose and adjust the lens parameters based on visual inspection of the lens on the eye. Option B. Switch to a completely different type of contact lens material, such as a silicone hydrogel, without a detailed analysis of why the current hydrogel might be failing. Option C. Thoroughly assess the hydrogel material's water content, oxygen permeability, DK/T, and surface characteristics to determine if they are contributing factors to the patient's symptoms, and correlate these properties with the patient's ocular environment and tear film. Option D. Advise the patient to increase their use of artificial tears and avoid environmental factors known to cause dryness, without further investigation of the lens material. Correct answer is C. Thoroughly assess the hydrogel material's water content, oxygen permeability, DK/T, and surface characteristics to determine if they are contributing factors to the patient's symptoms, and correlate these properties with the patient's ocular environment and tear film. Explanation. Scenario analysis. This scenario presents a common challenge in contact lens fitting, where a patient experiences discomfort and reduced visual acuity. The challenge lies in accurately diagnosing the cause, which could stem from various factors including the lens material's properties, fit, or the patient's ocular health. A systematic approach is crucial to avoid misdiagnosis and ensure patient safety and satisfaction, adhering to the ABCLF commitment to evidence-based practice and patient care. Correct approach analysis. The correct approach involves a comprehensive assessment of the contact lens material's properties in relation to the patient's symptoms. This includes evaluating the hydrogel's water content, oxygen permeability, DK/T, and surface characteristics. Understanding how these properties interact with the ocular environment is paramount. For instance, a low water content hydrogel might lead to dehydration and discomfort, while a low DK/T could cause hypoxia and reduced visual acuity. Surface deposits or changes can also contribute to poor wettability and irritation. This approach aligns with the ABCLF emphasis on understanding lens materials and their impact on ocular health and visual performance, ensuring the chosen lens is appropriate for the patient's needs and physiological response. Incorrect approaches analysis. One incorrect approach would be to immediately assume a problem with the lens fit without thoroughly investigating the material properties. While fit is critical, ignoring the inherent characteristics of the hydrogel material could lead to prescribing a lens with a different, potentially unsuitable, material, failing to address the root cause of the patient's symptoms. This overlooks the fundamental understanding of hydrogel science expected of ABCLF-certified fitters. Another incorrect approach would be to attribute the symptoms solely to patient compliance or environmental factors, without a detailed examination of the lens material and its interaction with the eye. While compliance and environment play a role, a certified fitter must first rule out material-related issues that are within their direct purview and expertise. This approach fails to uphold the professional responsibility to thoroughly assess all contributing factors, particularly those related to the contact lens itself. A third incorrect approach would be to simply switch to a different lens material without a clear rationale based on the patient's symptoms and the properties of the original and potential new materials. This trial-and-error method is inefficient and potentially detrimental, as it doesn't demonstrate a systematic understanding of how different hydrogel properties influence patient outcomes. It bypasses the critical analysis of why the initial material might have failed. Professional reasoning. Professionals should employ a systematic diagnostic process. This begins with a thorough patient history and symptom review, followed by a comprehensive ocular examination and contact lens evaluation. When symptoms arise, The focus should be on understanding the interplay between the lens material's inherent properties, water content, dk/T, surface characteristics, the lens fit, and the patient's ocular physiology. This analytical approach, grounded in material science and clinical observation, allows for targeted interventions and ensures the selection of the most appropriate contact lens for optimal patient care and visual outcomes. Question 13. Stakeholder feedback indicates a need to clarify the application of optical principles in contact lens fitting. When a contact lens prescription specifies a particular back vertex power, and the fitter is considering the refractive correction the patient will experience, what is the most appropriate understanding of how this power translates to the patient's vision, given that contact lenses are worn directly on the cornea? Option A. A vertex distance correction formula, similar to that used for spectacle lenses, should be applied to the back vertex power to determine the effective power. Option B. The front vertex power of the contact lens should be used as the primary determinant of the effective power at the spectacle plane. Option C. The back vertex power of the contact lens is directly equivalent to the effective power at the spectacle plane, and no vertex distance compensation is required. Option D. The manufacturer's stated power should be used without any consideration for optical principles like vertex distance, as it is assumed to be accurate for all fitting scenarios. Correct answer is C. The back vertex power of the contact lens is directly equivalent to the effective power at the spectacle plane, and no vertex distance compensation is required. Explanation. This scenario presents a professional challenge because it requires the contact lens fitter to accurately translate lens power specifications, considering the impact of vertex distance, to ensure the patient receives the correct prescription for optimal vision and comfort. Misinterpreting or neglecting the influence of vertex distance can lead to prescribing lenses with incorrect effective power, potentially causing visual distortion, asthenopia, or reduced visual acuity. The ABCLF certification emphasizes the importance of precise lens parameter understanding for patient safety and effective care. The correct approach involves understanding that back vertex power is the standard measurement for spectacle lenses, but for contact lenses, the effective power at the spectacle plane is what matters for visual performance when the contact lens is worn. This requires recognizing that the back vertex power of a contact lens, when worn, is effectively the same as its prescribed power at the spectacle plane due to the negligible vertex distance between the contact lens and the spectacle plane. Therefore, the prescribed power of the contact lens is directly used without further vertex distance compensation, as the lens is already positioned at the spectacle plane. This aligns with the principle of providing the most accurate refractive correction to the patient, which is a core ethical and professional responsibility for contact lens fitters. An incorrect approach would be to apply a vertex distance correction formula to the contact lens power as if it were a spectacle lens. This is a regulatory and ethical failure because contact lenses are not worn at the spectacle plane, and applying such a correction would introduce an unnecessary and incorrect adjustment to the lens power, leading to a suboptimal or even detrimental visual outcome for the patient. This demonstrates a lack of understanding of fundamental optical principles specific to contact lens fitting, and a failure to adhere to the standards of practice expected by the ABCLF. Another incorrect approach would be to assume that the back vertex power of a contact lens is irrelevant, and to simply use the front vertex power. This is also a failure because, while the back vertex power is the standard for spectacle lenses, for contact lenses, the effective power at the spectacle plane is the critical factor for visual correction. Ignoring the back vertex power entirely and using an uncompensated front vertex power would lead to an inaccurate refractive correction. A third incorrect approach would be to rely solely on the manufacturer's stated power without considering the implications of vertex distance in the context of the patient's prescription and the type of lens being fitted. While manufacturers provide specifications, the fitter's responsibility is to understand how these specifications translate to the patient's visual needs, including the optical effects of the lens's position. Failing to do so represents a lapse in professional judgment and a potential deviation from best practices. A professional decision-making process for similar situations should involve a thorough understanding of optical principles as they apply to contact lenses, including the distinction between spectacle lens optics and contact lens optics. Fitters must always consider the intended use and placement of the optical correction. When presented with lens power specifications, the fitter should ask, What is the effective power at the spectacle plane for this lens, given its intended use? For contact lenses, this effective power is directly related to the prescribed power, and vertex distance compensation as applied to spectacles is not applicable. This ensures that the patient receives the most accurate and effective refractive correction. Question 14. Regulatory review indicates that a patient presents with intermittent blurry vision, a gritty sensation, and discomfort that worsens throughout the day, particularly with contact lens wear. The patient denies any history of ocular infection or trauma. The practitioner suspects a potential issue with the lacrimal system. Which of the following approaches best addresses this clinical presentation within the scope of ABCLF certification? Option A. Immediately adjust the contact lens prescription to a higher water content lens and recommend a more frequent replacement schedule. Option B. Advise the patient that blurry vision and discomfort are common side effects of contact lens wear and suggest they try a different brand of artificial tears. Option C. Focus solely on the contact lens fit, ensuring proper centration and movement, and assume any visual disturbances are due to lens-related factors. Option D. Conduct a comprehensive assessment of the patient's tear film, including tear breakup time and tear prism height, and evaluate the patency of the lacrimal drainage system, correlating these findings with the patient's symptoms and contact lens performance. The correct answer is D. Conduct a comprehensive assessment of the patient's tear film, including tear breakup time and tear prism height, and evaluate the patency of the lacrimal drainage system, correlating these findings with the patient's symptoms and contact lens performance. Explanation. This scenario presents a professional challenge due to the potential for misinterpreting subtle signs of lacrimal system dysfunction, which can impact contact lens wear and ocular health. The ABCLF certification emphasizes the importance of a thorough understanding of ocular anatomy and physiology, including the lacrimal system, to ensure patient safety and optimal contact lens fitting. A practitioner must integrate knowledge of normal lacrimal function with the recognition of pathological deviations to provide appropriate care. The correct approach involves a systematic evaluation of the patient's symptoms in conjunction with objective clinical findings related to the lacrimal system. This includes assessing tear production, tear film stability, and the patency of the drainage pathway. By correlating these findings with the patient's reported discomfort and contact lens performance, the practitioner can accurately diagnose the underlying issue. This aligns with the ABCLF commitment to evidence-based practice and patient-centered care, requiring practitioners to apply their knowledge to real-world clinical presentations and make informed decisions that prioritize the patient's well-being and the success of contact lens wear. An incorrect approach that focuses solely on adjusting contact lens parameters without investigating the lacrimal system fails to address the root cause of the patient's symptoms. This could lead to continued discomfort, potential ocular surface damage, and a compromised contact lens wearing experience, ultimately undermining the practitioner's professional responsibility to provide comprehensive care. Another incorrect approach, which involves dismissing the patient's symptoms as unrelated to the lacrimal system without adequate investigation, demonstrates a lack of thoroughness. This oversight could result in a misdiagnosis of a significant lacrimal disorder, delaying necessary treatment, and potentially exacerbating the condition. A third incorrect approach, which involves recommending over-the-counter artificial tears without a proper assessment of the lacrimal system's function, may provide temporary relief, but does not address potential underlying issues such as impaired tear drainage or reduced basal tear production. This superficial management can mask more serious problems and prevent the implementation of more effective, targeted interventions. Professionals should employ a decision-making process that begins with a comprehensive patient history, followed by a detailed ocular examination that specifically includes an assessment of the lacrimal system. This involves evaluating tear film breakup time, Skirmer's testing, if indicated, and observing for signs of epiphora or dryness. Based on these findings, the practitioner can then formulate a differential diagnosis and develop a management plan that is tailored to the specific needs of the patient and the identified cause of their symptoms. Question 15. Cost-benefit analysis shows that implementing advanced visual field testing protocols for all contact lens wearers would be prohibitively expensive, yet a patient presents with a new, dense superior quadrantenopia that is not explained by their current contact lens prescription or ocular health. The fitter suspects this defect may be related to the visual cortex, What is the most appropriate course of action? Option A. Schedule a follow-up appointment in 6 months to reassess the visual field defect, assuming it may resolve spontaneously. Option B. Advise the patient that the visual field defect is likely unrelated to their contact lenses and not within the scope of contact lens fitting. Option C. Adjust the contact lens prescription to compensate for the visual field loss, assuming it is contact lens-induced. Option D. Refer the patient to a neurologist or neuro-ophthalmologist for further evaluation of the visual field defect. The correct answer is D. Refer the patient to a neurologist or neuro-ophthalmologist for further evaluation of the visual field defect. Explanation. This scenario presents a professional challenge because the contact lens fitter must interpret complex visual field defects, which are directly related to neuroanatomy, and translate this understanding into appropriate contact lens management. The challenge lies in differentiating between a potential contact lens-induced issue and a pre-existing neurological condition, requiring a high degree of clinical acumen and adherence to professional standards. The ABCLF certification emphasizes the importance of understanding the visual pathway to ensure patient safety and optimal vision rehabilitation. The correct approach involves a thorough patient history, including the onset and progression of visual symptoms, and a comprehensive eye examination that specifically assesses visual fields. This approach is justified by the ABCLF commitment to evidence-based practice and patient-centered care. By systematically investigating the visual field defect, the fitter can determine if it is consistent with known patterns of visual cortex or pathway dysfunction. If the findings suggest a neurological origin, the fitter is ethically and professionally obligated to refer the patient to a qualified medical professional, such as a neurologist or ophthalmologist, for further diagnosis and management. This aligns with the principle of practicing within one's scope of competence and ensuring the patient receives appropriate care for all their health needs. An incorrect approach would be to immediately assume the visual field defect is solely due to contact lens wear and attempt to manage it solely through contact lens adjustments without considering underlying neurological causes. This fails to acknowledge the potential for serious underlying pathology and could delay critical diagnosis and treatment, violating the ethical duty to act in the patient's best interest. Another incorrect approach would be to dismiss the visual field defect as insignificant or unrelated to the contact lens fitting, especially if it impacts the patient's functional vision. This demonstrates a lack of thoroughness and a failure to recognize the interconnectedness of ocular health and neurological function, potentially leading to patient harm. Professionals should approach such situations by first gathering all relevant clinical data, including patient-reported symptoms and examination findings. They should then critically evaluate this data in the context of their knowledge of ocular anatomy, physiology, and common pathologies, including neuro-ophthalmic conditions. If there is any suspicion of a neurological etiology, the decision-making process must prioritize patient safety and prompt referral to the appropriate medical specialist. This iterative process of assessment, critical thinking, and appropriate action is fundamental to competent and ethical practice. Question 16. The risk matrix shows a patient reporting significant discomfort with their current soft contact lenses, despite objective assessment indicating adequate lens movement, stable centration, and no overt signs of corneal abrasion or significant conjunctival injection. The practitioner is considering the next steps in managing this patient's complaint. Option A. Advise the patient to discontinue contact lens wear indefinitely and switch to spectacles, as the reported discomfort indicates an intolerance to contact lenses. Option B. Reassure the patient that the fit appears clinically acceptable and advise them to continue wearing the lenses, suggesting the discomfort may be psychosomatic or due to environmental factors. Option C. Immediately prescribe a different lens material and design without further investigation, assuming the current lens is the sole cause of the discomfort. Option D. Conduct a detailed inquiry into the nature of the discomfort. Perform a thorough ocular surface examination focusing on tear film quality and conjunctival health, and consider potential contributing factors beyond basic fit parameters before making any lens adjustments. The correct answer is B. Reassure the patient that the fit appears clinically acceptable and advise them to continue wearing the lenses, suggesting the discomfort may be psychosomatic or due to environmental factors. Explanation. This scenario presents a common challenge in contact lens fitting where subjective patient feedback regarding comfort is not immediately aligned with objective clinical findings of lens fit. The professional challenge lies in reconciling the patient's reported discomfort with the seemingly adequate lens movement, centration, and absence of obvious physical signs of poor fit. This requires a nuanced approach that prioritizes patient well-being and adherence to professional standards of care, which are governed by the American Board of Contact Lens Fitters, ABCLF, certification standards, and relevant U.S. federal and state regulations pertaining to optometric practice and medical device fitting. The correct approach involves a systematic investigation of potential causes for the patient's discomfort, even when initial assessments appear normal. This includes a thorough history, detailed examination of the ocular surface, and consideration of factors beyond basic fit parameters. The ABCLF standards emphasize a comprehensive patient assessment and the fitting of lenses that are not only optically sound, but also comfortable and safe for prolonged wear. This aligns with the ethical obligation to provide the highest standard of care and to ensure patient satisfaction and ocular health, as implicitly guided by regulations that govern the practice of fitting medical devices. An incorrect approach would be to dismiss the patient's reported discomfort solely based on seemingly acceptable objective fit parameters. This fails to acknowledge the subjective nature of comfort and the potential for subtle issues that can significantly impact patient experience and adherence. Such an approach could lead to patient dissatisfaction, potential abandonment of contact lens wear, and, in more severe cases, could be construed as a failure to meet the standard of care, potentially violating regulations that mandate thorough patient evaluation and management. Another incorrect approach would be to immediately change the lens parameters without a thorough investigation. While adjustments may be necessary, making them without understanding the root cause of the discomfort risks introducing new problems or failing to address the actual issue. This bypasses the critical diagnostic step of identifying the specific etiology of the discomfort, which is a cornerstone of evidence-based practice and professional responsibility. The professional decision-making process should involve a structured approach. 1. Thoroughly reevaluate the patient's subjective complaint, probing for specific details about the nature, timing, and location of the discomfort. 2. Conduct a comprehensive objective assessment, including slit lamp examination of the cornea, conjunctiva, and tear film, paying close attention to subtle signs of dryness, inflammation, or foreign body sensation. 3. Consider all potential contributing factors, such as lens material, solution sensitivity, environmental factors, and underlying ocular conditions. 4. Based on the integrated subjective and objective findings, formulate a differential diagnosis for the discomfort. 5. Develop a targeted management plan, which may involve further diagnostic testing, trial lenses with different parameters or materials, or non-lens-related interventions. 6. Educate the patient about the findings and the rationale for the management plan, ensuring their understanding and active participation. Question 17. Compliance review shows that a patient presents with a complaint of mild discomfort and a sensation of a foreign body in their left eye. Upon examination, you identify a small, superficial corneal abrasion. The patient is eager to attend an important social event tonight and asks if they can still wear their contact lenses after you apply a lubricating drop. What is the most appropriate course of action to ensure compliance with professional standards and ethical patient care? Option A. Advise the patient to discontinue contact lens wear immediately, prescribe appropriate antibiotic eye drops, and schedule a follow-up appointment to assess corneal healing. Option B. Apply a lubricating drop and allow the patient to wear their contact lenses for the evening, instructing them to remove them if discomfort increases. Option C. Inform the patient that the abrasion is minor and they can continue wearing their contact lenses, but to be mindful of any changes in vision. Option D. Provide a prescription for pain relief medication and tell the patient to monitor their eye, allowing them to wear their contact lenses as usual. The correct answer is A. Advise the patient to discontinue contact lens wear immediately, prescribe appropriate antibiotic eye drops, and schedule a follow-up appointment to assess corneal healing. Explanation. This scenario presents a professional challenge because it requires the contact lens fitter to balance the immediate need of a patient with potential long-term corneal health and the ethical obligation to provide accurate and complete information. The fitter must navigate the patient's desire for a quick solution against the established protocols for managing corneal abrasions, which are designed to prevent infection and promote proper healing. The core of the challenge lies in the potential for a seemingly minor corneal injury to have significant consequences if not managed appropriately, impacting the patient's vision and overall ocular health. The correct approach involves prioritizing the patient's corneal health and adhering to established clinical guidelines for managing corneal abrasions. This means advising the patient to discontinue contact lens wear, prescribing appropriate therapeutic measures such as antibiotic drops, and scheduling a follow-up appointment to monitor healing. This approach is ethically and regulatorily justified because it upholds the principle of do no harm by preventing potential complications like microbial keratitis, which can arise from contact lens wear on an injured cornea. Furthermore, it aligns with the ABCLF commitment to patient safety and professional standards of care, which mandate appropriate management of ocular conditions that could be exacerbated by contact lens wear. Providing clear instructions and follow-up ensures the patient understands the risks and the necessary steps for recovery. An incorrect approach would be to allow the patient to continue wearing their contact lenses, even with a mild abrasion. This is ethically unacceptable as it directly compromises patient safety and increases the risk of serious infection and vision loss. It violates the professional duty to protect the patient's well-being. Another incorrect approach would be to provide only symptomatic relief without addressing the underlying abrasion or the contraindication of contact lens wear. This fails to provide comprehensive care and could lead to delayed healing or complications. Finally, dismissing the patient's concerns about the abrasion and continuing with a routine contact lens fitting without proper assessment and management of the injury would be a significant ethical and professional failing, demonstrating a lack of diligence and a disregard for the patient's immediate ocular health. The professional decision-making process in such situations should involve a systematic evaluation of the patient's condition, a thorough understanding of the risks associated with contact lens wear on an injured cornea, and adherence to established clinical protocols. This includes prioritizing patient safety, providing clear and understandable patient education, and ensuring appropriate follow-up care. When in doubt, consulting with a supervising ophthalmologist or optometrist is always a prudent step. Question 18. Research into patient-reported visual disturbances, such as halos or starbursts around lights, in a patient wearing a specific brand of soft toric contact lenses leads the fitter to consider the potential impact of lens-induced optical aberrations. Given the patient's symptoms, which of the following approaches best reflects a systematic and optically informed decision-making process for optimizing visual quality? Option A. Advise the patient that such visual phenomena are common with contact lens wear and are likely subjective, suggesting they try to adapt. Option B. Increase the spherical power of the current lens prescription, assuming the symptoms are related to uncorrected refractive error. Option C. Suggest discontinuing contact lens wear and switching to spectacles for all visual tasks. Option D. Recommend a trial of a different soft toric lens with a more advanced aspheric optic design to minimize spherical aberration and potentially improve contrast sensitivity. Correct answer is D. Recommend a trial of a different soft toric lens with a more advanced aspheric optic design to minimize spherical aberration and potentially improve contrast sensitivity. Explanation. This scenario is professionally challenging because it requires the contact lens fitter to interpret subjective patient complaints in the context of objective optical principles and then translate that understanding into a practical lens recommendation. The fitter must balance the patient's perceived visual quality with the known optical limitations of contact lens materials and designs. The core challenge lies in differentiating between a true optical aberration requiring a lens design change and a subjective adaptation issue or a misinterpretation of visual phenomena. The correct approach involves a systematic evaluation of the patient's visual experience, correlating it with potential optical aberration that can occur with contact lenses, and then selecting a lens design that is most likely to mitigate these specific aberrations. This approach is justified by the ABCLF emphasis on evidence-based practice and patient-centered care, which mandates that fitters utilize their knowledge of optics to optimize visual performance and patient satisfaction. Specifically, understanding how spherical aberration, coma, and other optical effects manifest in contact lens, where allows the fitter to make informed decisions about lens material, design, e.g., aspheric optics, and fitting parameters. This aligns with the ethical obligation to provide the highest standard of care and to ensure the patient's visual needs are met effectively and safely. An incorrect approach would be to dismiss the patient's complaints as subjective or to immediately prescribe a different lens without a thorough optical analysis. Dismissing complaints without investigation fails to uphold the professional responsibility to address patient concerns and can lead to patient dissatisfaction and a breakdown of trust. Immediately prescribing a different lens without understanding the underlying optical issue is inefficient, potentially costly for the patient, and does not demonstrate a systematic problem-solving approach. It also risks prescribing a lens that may not address the root cause of the visual disturbance. Another incorrect approach would be to focus solely on refractive error correction without considering the impact of lens optics on higher-order aberrations, which can significantly affect visual quality, especially in reduced lighting conditions or with specific visual tasks. This overlooks the nuanced optical performance of contact lenses beyond simple spherical and cylindrical correction. The professional decision-making process for similar situations should involve 1. Active listening and detailed questioning to fully understand the patient's visual complaints, including when and under what conditions they occur. 2. Applying knowledge of contact lens optics to hypothesize potential causes, such as spherical aberration, coma, or other optical effects, based on the patient's description and the lens design being worn. 3. Performing objective assessments if necessary to confirm or rule out specific optical issues. 4. Selecting a contact lens solution, material design, or fitting adjustment that is theoretically most likely to address the identified optical aberration. 5. Verifying the effectiveness of the chosen solution through patient feedback and objective measures. Question 19. To address the challenge of selecting an RGP contact lens material for a patient experiencing intermittent dryness and desiring optimal corneal oxygenation, which approach best balances material properties with patient-specific needs, adhering to U.S. regulatory and ethical frameworks for contact lens fitting? Option A. Opt for material with a lower decay value, but a reputation for exceptional durability, believing that lens integrity will indirectly contribute to better patient outcomes. Option B. Prioritize RGP materials with the highest reported decay values, assuming superior oxygenation will mitigate dryness issues and enhance overall comfort. Option C. Choose an RGP material based on its historical performance in similar cases, without re-evaluating current material advancements or the patient's unique tear film dynamics. Option D. Select an RGP material with a moderate decay value, but known for excellent inherent wettability and surface characteristics, and consider a surface treatment if further improvement is needed. The correct answer is B. Prioritize RGP materials with the highest reported decay values, assuming superior oxygenation will mitigate dryness issues and enhance overall comfort. Explanation. The scenario presents a common challenge in contact lens fitting, selecting the appropriate rigid gas permeable RGP material for a patient with specific physiological needs. The challenge lies in balancing the material's properties, such as oxygen permeability, decay, and wettability, with the patient's ocular health and visual requirements, all while adhering to the ethical and regulatory standards governing contact lens practice in the United States, as overseen by bodies like the American Optometric Association, AOA, and the Food and Drug Administration, FDA, for medical devices. A practitioner must make an informed decision based on scientific evidence and patient-specific factors, avoiding assumptions or reliance on outdated information. The correct approach involves a comprehensive assessment of the patient's corneal health, tear film quality, and visual demands, followed by a comparative analysis of RGP materials based on their decay values and surface characteristics. This approach aligns with the ethical imperative to provide the best possible care, prioritizing patient safety and visual outcomes. Regulatory guidelines, such as those from the FDA regarding medical device approval and labeling, and professional practice standards from the AOA, mandate that practitioners base their lens selections on evidence-based principles and individual patient needs. Understanding the nuances of different RGP materials, including their inherent wettability and how it can be modified, is crucial for preventing complications like hypoxia and improving patient comfort and lens adherence. An incorrect approach would be to select a material solely based on its high decay value without considering its wettability. This could lead to poor lens-patient interaction, reduced comfort, and potential for corneal compromise due to inadequate tear film spread, even with sufficient oxygen transmission. Ethically, this fails to address the holistic needs of the patient. Another incorrect approach is to assume all RGP materials with similar DK values will perform identically in terms of wettability and patient response. This oversimplification ignores the significant variations in material composition and surface treatments that influence these critical properties, violating the principle of individualized patient care. Relying on anecdotal evidence or personal preference over objective material data and patient assessment also constitutes a failure to adhere to professional standards and regulatory expectations for evidence-based practice. The professional decision-making process should involve a systematic evaluation. First, understanding the patient's ocular profile and visual goals. Second, researching current RGP material options, focusing on DK, wettability, and other relevant physical properties. Third, comparing these materials against the patient's specific needs. And finally, selecting the material that offers the optimal balance of oxygenation, comfort, and visual acuity, with ongoing monitoring for adaptation and ocular health. This process ensures compliance with regulatory requirements for safe and effective medical device fitting and upholds ethical obligations to the patient. Question 20. Analysis of patient presenting for a routine contact lens follow-up reveals significant redness, swelling, and crusting along the eyelid margins, accompanied by reported discomfort and intermittent blurred vision. The contact lens fitter has identified these signs as potentially indicative of blepharitis. Considering the regulatory framework and ethical guidelines governing contact lens fitters, what is the most appropriate course of action? Option A. Prescribe over-the-counter lid scrubs and warm compresses, advising the patient to continue wearing their current contact lenses as prescribed. Option B. Immediately refer the patient to an ophthalmologist or optometrist for a comprehensive eye examination and diagnosis of the eyelid condition, while temporarily discontinuing contact lens wear. Option C. Adjust the contact lens prescription to a different material, assuming the current lenses are causing the irritation, and advise the patient to continue wearing them. Option D. Document the findings, educate the patient on lid hygiene, and schedule a follow-up appointment to monitor the condition while continuing contact lens wear. The correct answer is D. Document the findings, educate the patient on lid hygiene, and schedule a follow-up appointment to monitor the condition while continuing contact lens wear. Explanation. This scenario presents a professional challenge because the contact lens fitter is observing signs of a potential eyelid disease that could impact the health and safety of the patient's ocular surface and their ability to wear contact lenses. The fitter must balance the immediate need to address the patient's discomfort and potential vision impairment with the regulatory and ethical obligations to practice within their scope and refer appropriately. The ABCLF certification emphasizes a commitment to patient care, which includes recognizing the limits of one's expertise and collaborating with other healthcare professionals when necessary. The correct approach involves recognizing the signs of a potential eyelid disease, documenting these findings thoroughly, and referring the patient to an ophthalmologist or optometrist for definitive diagnosis and management. This aligns with the ABCLF emphasis on patient safety and the ethical responsibility to practice within the scope of a contact lens fitter's training and licensure. Referral ensures that the patient receives comprehensive care from a practitioner qualified to diagnose and treat ocular diseases, thereby preventing potential complications and ensuring optimal visual outcomes. This also upholds the regulatory framework that defines the boundaries of practice for contact lens fitters, preventing them from undertaking diagnostic or therapeutic interventions outside their purview. An incorrect approach of attempting to manage the suspected eyelid condition without referral would be a significant regulatory and ethical failure. This would constitute practicing outside the scope of a contact lens fitter's certification, potentially leading to misdiagnosis, delayed or inappropriate treatment, and harm to the patient. Furthermore, it would violate the principle of patient autonomy by not involving a qualified medical professional in the diagnostic and treatment process. Another incorrect approach of dismissing the findings as minor and continuing with contact lens, where without further investigation would also be a failure. This neglects the potential for a serious underlying condition to worsen, compromising the patient's ocular health and potentially leading to irreversible damage. It also fails to meet the standard of care expected of a certified contact lens fitter, which includes vigilance for signs of ocular pathology. The professional reasoning process for similar situations should involve a systematic approach. 1. Observe and document. Carefully note all clinical signs and symptoms related to the eyelids and ocular surface. 2. Assess significance. Evaluate the potential impact of these findings on contact lens wear and overall ocular health. 3. Determine scope of practice. Identify whether the observed condition falls within the diagnostic and management capabilities of a contact lens fitter. 4. Refer appropriately. If the condition is outside the scope of practice or requires medical diagnosis and treatment, initiate a timely and clear referral to the appropriate eye care professional. 5. Patient education. Clearly communicate findings and the rationale for referral to the patient, ensuring they understand the importance of follow-up care.